The next session will be by Dr. Debashish Das. The topic will be Art and Science and Economics on Congenital Heart Surgery in India. I would like Dr. Hiremat and Dr. Jagannath to join as chairpersons. Dr. Manoj will be joining later on. Thank you.
DASTUR oration.
Yeah, I request Dr. Debasis Das to deliver the K.N. DASTUR memorial oration, please.
Thank you, sir. Good morning, everybody. It is a daunting task to speak right after Dr. Sano. First of all, thanks to the association for bestowing the honor of delivering the K.N. DASTUR Memorial Oration 2025, and also to the organizing committee. In the next 30 minutes or so, I will talk about the art, science, and the economics of congenital heart surgery in India. I have no disclosures. All the pictures that you see are with permission. I'll start with homage to Dr. K.N. DASTUR, pioneer, teacher, master surgeon, and a legend. And it is only apt that this topic is very relevant because he was one of the initial trailblazers in this arena. What I would want to do is, I would draw important parallels between art and congenital heart surgery. There are some striking parallels. I would also dwell upon how science has developed in India in this particular subspecialty and touch upon the economic part of it. I've chosen 3 common paintings. I have a disclaimer to make. I'm no art connoisseur. I dabble in it a bit, and that is what I know about it. I've chosen common paintings, so most of us will identify with it. Mona Lisa by Leonardo da Vinci, The Persistence of Memory by Salvador Dali, and The Last Supper again by Leonardo da Vinci. What I find is the intersection between art and congenital heart surgery reveals fascinating parallels. We probably require the same degree of creativity, the same degree of precision, and the same degree of innate understanding of complexity and physiology like it is required to make a masterpiece of an art like this. Mona Lisa by Leonardo da Vinci, it has been in the Louvre in Paris since 1797, an archetypal masterpiece of the Italian Renaissance. The subtle expressions that we see in this painting, there is an enigmatic smile, very famous. It is the most visited museum object in the world, and the smile appears to change at the angles that you see. It is achieved through an art technique called sfumato. It is a technique of blending, of soft blending without hard lines. When you look at Mona Lisa's eyes, it seems to follow the viewer. It is almost like a lifelike interaction. It also, what we miss when we see Mona Lisa is the background. So in the background, there are winding rivers, rocky mountains, misty alleys, and that is what completes the entire picture. Also, if you see the proportion of the fingers, the face, the nose, I think this is a testament to Leonardo da Vinci's innate understanding of the anatomy, and we know that he was a master anatomist. If I have to draw a surgical parallel with Mona Lisa, the surgery is arterial switch, and I think there is an art of subtle transition and balancing complexity in this particular operation. We also need the same degree of seamless reconstruction, creating smooth, natural transitions between tiny 1 millimeter coronary arteries. Like Leonardo da Vinci's blending of light and shadow with the technique called sfumato, we also need to have the sutures right in place to suture 1 millimeter coronaries without obstruction, without leaks. And in the whole picture, we also we have to be very conscious not to lose the sight of things like VSDs, which would actually integrate this with the surrounding, because that will have an important impact on the outcome. The attention to proportions, of course, there are disparities in the pulmonary artery and the aortic size, and those are things which are important parallels like Mona Lisa. Every time a congenital heart surgeon does an arterial switch successfully in an operating room, I feel he is creating a Mona Lisa on that particular day. The second one that I've chosen is Persistence of Memory by Salvador Dali. He was a very famous painter of the Surrealism school of art. He was also famous for his moustache. Some of you are familiar with the Dali mask, which was very popularized during the Money Heist telecast in the Netflix. What it symbolizes is these melting clocks actually show flexibility, the time, the innovation, and the fluidity of time is very very similar to how we have to adapt to situations in our operating rooms. It is also very innovative and imaginative, just like we saw Dr. Thomas showing us the VR reality, the imagination that we need before an operation to imagine the post-operative circulatory stage. I think that is the degree of imagination which is symbolized in this particular painting. If I have to draw a surgical parallel, I would choose Rastelli and Fontaine. These are the operations in which we have to understand the anatomy, we have to imagine a lot of things before we actually plan the operation, and that is the similarity between the persistence of memory and these operations. The last painting, till I visited Milan, I actually didn't know that the Last Supper is not actually a painting but a wall mural. And I was pleasantly surprised. It's a stunning piece of work. And in addition to the centrality of the figure of Jesus, there are 12 apostles who are equally important. And it symbolizes collaboration, storytelling, and composition. I think if I have to draw a surgical parallel, I couldn't find an operation. I think this defines the team dynamics in the operating room. Like the 12 apostles in the Last Supper, each member of our surgical team contributes in a manner which has important bearing on the ultimate outcome. It is also about handling complexities, and not only anatomical complexities, but moments filled with tension, betrayal, hope. Just like we go through all these emotions during a complex operation, also the family has the same degree of apprehension while waiting for this procedure to get over. It is a technical mastery in composition. It is also a symbolic impact. If you notice carefully, there is Judas in that painting with a bag of silver, and that is probably that detail which is needed, that subtle angle of your graft, that subtle extra stitch that you take on the mitral valve, that is the nuance of the entire thing which completes the picture. So I think these are the parallels of art and congenital heart surgery. I would go on to something more non-abstract and go into the realm of science now. And how do we actually, what are the metrics to be evaluated, how we as a country have contributed to the scientific contribution in the realm of congenital heart surgery. The quantum of surgery that we do in this country, the scientific publications from this country, the surgical innovations from India. Again, I admit that there is a lack of a robust database. This is based again on personal communication and the industry data. Approximately what we do in this country is approximately 35,000 to 40,000 congenital heart surgeries per annum. Our disease burden is huge, with a prevalence of 8 to 12 per 100,000 live births, and a population of 1.4 billion, and a birth rate of 16.1 per thousand. Every year, we have 200,000 children born with important congenital heart defects, and 1/5, that is 20% of them, will actually require an intervention or a surgery in the first year of life. This is Dr. Anita Saxena's seminal paper. This is the second of the series. This was published in 2018, which talked about the same challenges. It also highlighted the disparities in the geographical distribution of access to care. A lot of water has flown after the bridge, and I'm sure by the time the next status report is published, a lot of things have evened out in terms of improved access. This particular paper showed that the southern part of India had a natural advantage, and the access to care in this particular geographical region was best there. However, again, this is a representative figure and not exhaustive. The size of the bubble shows the size of the program. I've intentionally not named the centers. And you can see that this figure almost has an equal distribution, more or less, in many of the geographical directions. There are important gap areas, but if you compare it to a figure made, say, 10 years ago, I think we as a collective group of professionals delivering this particular aspect of cardiac surgery have made a progress in that area. And this is not a small quantum of work. Coming to the next aspect, what are the scientific contributions from India in congenital heart surgery? When I searched the PubMed the last 10 years, I think it was a pleasant surprise to see, this includes case reports and every form of publication, and there are close to around 100 papers every year. And if you look more closely, 2021 and 22, I think all of us had more time, and there are almost 170 papers. It is a small start. I think there is a lot of improvement in this aspect which is needed, but at least we have contributed something. When I delve into it a little bit more, this is a systematic review of all the randomized controlled trials in congenital heart surgery, which by any means is a rarity. It is not very easy to conduct RCTs in congenital heart surgery. And this analyzed 333 papers from 34 countries, and we didn't do too badly. So we were third, although it is a minuscule compared to 25% from China and 19% from US. 6.3% of these trials came from India. This is a pictorial representation of the same thing, and you can see that there is a dot in our country, and the size of the dot is not too small. So in a small way, we do have contributed to this aspect. Dr. Yadava is here, and we had a special issue in our Indian journal dedicated to congenital heart surgery, and he aptly wrote that congenital heart surgery avidly awaits evidence. We agree, and the lack of substantial data is universal. We are no exception. The entire world deals with it, mainly because our subset of every cohort is heterogeneous. They are small, and it is difficult to have large randomized controlled trial sort of data in congenital heart surgery. However, that does not absolve us of this responsibility, and we do need to rise up to the occasion. Coming to the innovations from India in congenital heart surgery, is only apt that I again take the name of Dr. K.N. DASTUR. He was probably one of the initial trailblazers, as I said. With the help of National Steel Company in Mumbai, Dr. DASTUR made the country's first totally indigenous heart-lung machine in 1959, did a series of dog experiments which were successful, and then finally closed in a 19-year-old girl an ASD in 1961, which was probably the beginning of congenital heart surgery in India. Largely unknown to the world, in Calcutta, the city where I have been working for more than a decade now, Dr. Saibal Gupta was improving upon the Lilly model of heart-lung machine. And he also did a series of successful dog experiments, and along with Dr. A.K. Basu, performed 9 successful ASDs in the year 1962, and this was published in the Journal of Indian Medical Association. Coming from there, so we started really early in innovation phase. There are a lot of innovations in devices which has happened from India. There are modifications, indigenous modifications of the CPB machine. There are devices for apical muscular VSDs, multiple muscular VSDs, handmade conduits for RVOT. We have had tissue engineered patches developed here, ECMO improvisations, use of adult stabilizing devices in Fontan surgeries. Based on our economic needs, we have also innovated in frugal technologies, use of CPB machine for ECMO, use of simple things like a blood bag or an Eschmarch bandage for keeping the chest open in neonatal surgeries, use of intraoperative epicardial echocardiography when TE is not available, use of electrocautery maze when our radiofrequency probe is not available. So these are the innovations in frugal technology. This is again a pictorial representation of the same. You can see that is the CPB machine, Dr. Bissoy's paper in late arterial switches for the purpose of ECMO. The other one is a patented device from UN Mehta for apical muscular VSDs by Dr. Amit Mishra. This is a AIMS modification of the unidirectional valve patch used in significant pulmonary artery hypertension patients who are late presenters. And these are some of the important devices which have been innovated from India. Again, this is a list of innovations in surgical techniques. And the list is not exhaustive, but I've tried to cover as much as we can. So unidirectional valve patch, TAPVC repair by a posterior approach. One of the first randomized trial comparing transatrial transventricular approach for tetralogy was published from India. Fixed versus dynamic gradients in post-op tetralogy was first described from India. Criteria for LV preparedness, use of extended CPB ECMO, popularization of the closed technique for coronary transfer, simplified modified sending for TGA TAPVC, and the list is endless. Adjustable PA bands, beating heart Fontan, midline off-pump coarctation repair, modifications in the atrial switch. India has published the largest number from UN Mehta about anomalous right coronary artery from pulmonary artery. Non-sternotomy, midline sternotomy approaches for minimally invasive approaches, use of innovative patches for closing the ASDs like the right atrial wall patch which came from the Olina Institute. We have used our coronary transfer techniques from arterial switch experience to pediatric Bentals by using a trapdoor technique, Ross procedure with Dacron valve conduit in the RVOT. These are important innovations, some of which were driven by our economic needs, some of which were driven by late presentations, but they have significantly contributed to innovations. This is just a pictorial representation, a collage of the papers which talk about innovative surgical approaches from India.